Right, everyone, here we go. We're going to start with the cervical setups at this point. This is the second half of the trimester. So let's get started on those and see if we can get through them in short order. We're going to start with our seated setups. First is going to be a seated index pillar push. We're going to take a tissue pull P to A, medial to lateral, but first I'm going to stabilize the patient's head so I can do that. My contact point is PIP, either just proximal or just distal to that. We're going to come out to the articular pillar. I'm going to slide my stabilizing hand into position. I'm going to laterally flex around my contact, and then I'm going to rotate. My contact elbow is at my side, but it's not tucked. And I'm going to thrust based on which segment I'm contacting, and our lines of correction would be, if I'm in the upper cervical, it's going to be P to A, I to S, and that's above C4. If I'm in the lower cervicals, below C4, it's going to be P to A, slightly S to I. And if I'm on C4, it's just going to be P to A straight through. Now we've done the index pillar push. Now we want to try a pull move. So I'm going to stand in front of the patient at a 45-degree angle. I'm never going to step in between the patient's legs here. That's invading patient's personal space. If you need to get a little bit closer, come in. You can stand outside their feet and reach where you need to be. But you're going to reach across the patient with a chiropractic index contact right at the PIP, a broad contact, taking that same tissue pull, stabilizing the head, tissue pull, laterally flex, rotate, and then I'm going to pull based on which segment I'm contacting. I'm in the upper cervicals right now, so I'm going to pull P to A, I to S. I'm pulling back toward my shoulder here. If I'm in the lower cervicals, I'd pull slightly down with my elbow here. Okay? That is our seated pull move. Now we have a supine index pillar contact. So I'm going to have the patient lay down on their back. Headpiece is going to be level or slightly up, as you see it right now. I'm going to find the segment that I need to make my contact on. Let's just say C4 for right now. I'm going to stabilize with my indifferent hand. So my contact hand is going to be my right hand, indifferent hand being my left. I'm going to reach around and I'm going to stabilize, cupping the back of the patient's occiput with my index and chiropractic index finger extending into the cervical spine just above C4. I'm going to take a tissue pull, laterally flex, rotate. Now at C4, I want my elbow, for all of my cervicals in this position, I want my elbow below my segmental contact. At C4, I'm going to be coming straight across, going P to A here. Okay? If I were in the upper cervicals, I would have stepped around just a little bit more so I can get an I to S angulation. If it's in the lower cervicals, I wouldn't have to stand so far around the headpiece, shooting S to I. Now, I'm going to have you turn face down. You'll need to take your glasses off for me, please. Now, for our C2 to C7, we have some prone setups. And this is either an ipsilateral contact, a contralateral contact, or a bilateral contact. So I'm going to step around so you can see what I'm doing. In the prone position, I'm going to need to lower the headpiece some from where I was in supine. So the headpiece is coming down. I'm going to have the patient scoot down the table just a little bit. Keep coming. Because I want that space in between the headpiece and thoracic piece to be able to utilize that. Ipsilateral contact, again, lateral index, tissue pull, sliding out to the articular pillar, have the patient turn their head away from my contact, so she's going to turn to the left, follow through as she turns. Cup her ear, thenar on the mastoid, cupping the ear, a little bit of itis traction, and my forearm is slightly above my contact this time since it is a prone position. And my line of correction is going to be P to A, I to S in the upper cervicals, P to A, S to I in the lower cervicals, P to A straight through at C4. Now that's a prone ipsilateral contact. Contralateral contact will be with my inferior hand. Again, tissue pull. Have the patient turn their head away from my contact here, and I'm reaching across. I'm having to get over the patient a little bit more. Cup the ear again, thenar on the mastoid, a little bit of I to S traction. Now, straight away is going to be at C4, slightly I to S is going to be upper. Now, it's a little bit awkward, but it can be done to go a little bit S to I for the lower cervicals. Okay, straight down. We have a bilateral contact. This is where we'll take our hands, we'll put them together in this V formation, but it's going to point down, and we're going to contact bilaterally both articular pillars. This would be for a posterior listing. I'm going to be over the patient, and I'm going to thrust straight through if it's at C4. Again, slightly I to S for upper cervicals, slightly S to I for lower cervicals. Thrust equally through both hands for that posterior listing. Now I can use that same contact if I am wanting to adjust for a rotation restriction. In this instance, it'd be a right rotation restriction. I would be thrusting mainly through my opposite hand, so this one here, and this acts as stabilizing hand. So here. Now that would be if I have a patient that can't turn their head effectively, I may not be able to get them into position, and this is all that I can do. So that's for C2 to C7, were all the setups we just saw right now. Every one of those except for this prone position can be applied to C1, the Atlas. We do not have a prone contact for the Atlas setup, but we do have the seated push, the seated pull, and the supine push that we can make a contact on. The only difference being is that at C1, we are making our contact on the posterior aspect of the TVP rather than the articular pillar from C2 to C7. Okay, so setups look the same. Take into account where you are in the cervical spine for your line of correction, and you've got everything that you need. Last but not least, we're going to go through the occiput. Now, since I've got my patient in the prone position, let's just start here. I've got a prone, and we're going to lower the headpiece just a little bit more. There we go. I can adjust in the prone position for an AS occiput or a PS occiput with some slight differences. In both instances, we have a bilateral contact. So what I mean is I'm taking my thenars and I'm contacting the posterior inferior aspect of the occiput with my hands around the back of the occiput. If I am inferior to my contact and I've got the patient's chin tucked just a little bit, I'm going to thrust P to A, I to S with a little bit of wrist action going forward here, for an AS occiput. Now, if I had a PS occiput, I'd have the patient bring their chin up just a little bit, just like that. I'm going to make the same contact bilaterally on the inferior portion of the occiput. Hopefully they wouldn't have a big clippy in the back of their head. We're going to be right here, but I'm going to come over my patient now for this one, and I'm going to thrust straight through. My wrist action on this one is going to be just the opposite of before. I'm going to come P to A with a rotation, posterior rotation of my wrist. Now that's for a posterior superior occiput. And yes, you're adjusting into the table. Don't worry about that. The pads are there for a reason. But that's what we'll be using these two prone setups for. I'm going to have you turn over on your back. Now we're going to the supine position. Again, headpiece level or slightly up. Now, from the supine position, I have two setups for the occiput that I can do. I can set up for a posterior superior occiput, depending on which side, left posterior superior or a right posterior superior. And this is a supine occiput push move. Now, I'm going to be at the head of the table. I'm going to take the patient's head and I'm going to have them turn their head to expose the side that I need to make my contact on. I'm going to take a hypothenar contact inferior to the posterior occipital ridge. I'm going to slide above it and drop right back down on it, just like I'm hooking it. I am then going to bring the patient's head back to neutral position, dropping my elbow. I'm going to laterally flex. Again, this is occiput on C1. There's just a little bit of movement. Then I'm going to rotate slightly. Again, a little bit of movement. I might even step around just a bit. Keep my elbow lower than my contact. Forearm and fingers are in line with each other, pointing toward that opposite shoulder, and I'm thrusting P to A, S to I, lateral to medial. That's for our supine occiput push move. Now, we also have a supine occiput lift. In this instance, I'm going to stand at the side of the headpiece, and I'm going to have the patient turn their head away from me. So please turn to that side. Can you raise your head up just a little bit? I'm going to slide my superior hand underneath, cupping the ear with my fingers running straight down the cervical spine. And with my inferior hand, using my thenar, I'm going to take an I to S tissue pull up onto the mastoid, cup the ear, and then I am going to laterally flex occiput on C1, right here. It's not much movement. My line of correction is going to be lateral to medial and I to S. So I'll be going this direction here. Okay? Straighten up. All right. Now I'm going to have you sit up. Face that direction. All right. Now we're in the seated position for our occiput setups. First thing I want to talk about is the seated occiput lift. Now, just as a reminder, if I have a left lateral flexion restriction, which we are going to set up for, I am going to step forward with my left leg against the table, but not up on the table. And I'll be behind the patient midline so that she can lean back on my leg. And I can take the weight of the patient easily because I've got my legs staggered here. My right leg is back so that I can accept the weight and feel stable enough to do that. So that's what I'm going to do. I'm going to step up midline with my thigh, have the patient scoot back just a little bit more. Now lean back. There we go. And I'm accepting her weight and feel comfortable with it now that I'm in this position. Now, for the left lateral flexion restriction, I'm going to have her turn her head to her right, just that way. And I'm letting the patient determine how far they can turn their head. That's where she wants to go. That's where we'll make our setup. Now, I'm going to take my left hand. I'm going to take a tissue pull, P to A, I to S. I'm just going to go straight up and cup that ear, just like you see me doing. I am going to make sure that I've got her positioned about neutral in the middle of my chest. I'm going to reach around with my indifferent hand, my right hand in this instance. I'm going to back up my contact. Now, I'm a little bit hunched over here, so what I want to do is I want to straighten up. I'm going to bring my shoulders back, chest out, and I'm going to scoop with my hands. And this is all going to happen at the same time. So to bring her to pre-tension, here's what we're going to do. And you saw her straighten up for me. I know I've got her to pre-tension in that instance. Now that coordination of movement is what everybody's going to need to be sure to work on. Now that's an occipital lift. It's for in this instance, it was a left lateral flexion restriction. I could set up for a right rotation restriction. It would be that same setup. It's just the rotation aspect of it that we're paying more attention to. Okay? So that's our occipital lift in the seated position. Last but not least was something that we didn't go over in class. The last week we had a chance to get together. But I just want to quickly show everybody this. I'm going to again step up behind the patient. My feet are a little bit staggered, but I'm more midline with the patient this time. This is for an AS occiput, adjusting for an AS occiput in the seated position. Now, what you have learned at this point is with Gonstead, you have a blocker behind the patient's neck, and we would have a blocker of some sort as well, maybe a rolled up towel. And with Gonstead, you're taking your hands on their glabella here, or supraorbital ridge, backing it up, and you're taking your tissue pull superior to inferior. Ours looks pretty much the same, only I'm bringing my hands apart over each of the supraorbital ridges, and with my tissue pull, I'm coming down onto that ridge, but not over it. And my thrust is going to be a scooping motion downward here. Okay? Again, it's anterior superior occiput, I want to bring it down. Okay, and that's our other seated occiput move. And again, you're getting this on the video. We didn't actually talk about that when we had a chance in class, but I apparently had forgotten about it. I want to be sure that I mentioned this to you. And those are all of the setups for the cervical spine. With the previous video and this video, now you've got all the setups that we've gone over for the trimester. Hopefully this is just a quick review. Obviously there are a lot of other little details listed in the rubrics that you want to be sure that you look at and go through. At present, just to remind everybody, I know that all of us are in a new and unique situation. We are still in flux as far as how we are going to be doing our testing. I will be in touch with you this week in the next day or two as to what decisions have been made as far as our final practicals and how we're going to handle all of that. I hope everyone is doing well. I hope all of your other classes are going well, and I'm looking forward to seeing you again soon. Take care.